also the field of view. Now, would you still say that SUV alone would be for example, to determine the presence or maybe a disease using the PET-CT? So I'm asking this question from Nairobi, Kenya.
Hello, Mr. Kapil. I think we have lost Dr. Kiruka from the participant as he was already on some holiday. So now, can I ask Dr. Pankaj or Dr. Ashish Kumar Jha sahab, can you comment on this? Hello?
Dr. Rajni, am I audible?
Yes, yes.
Actually, I didn't hear his question completely. Can I request him to repeat?
Yeah. Mr. Kapil, can you repeat the question, please?
So the question is, we have seen there are so many factors affecting the SUV. One of them is the construction algorithm that is being used. Some of them are the noise level of the imaging equipment that is being used. Others, he has stated, for example, field of view. So would we still say that SUV alone as a standard of measure is the tool that we can use to determine, for example, the presence of a disease or using the PET or SPECT-CT image, or maybe to determine the progress of therapy? Is there any other tool that we could use other than the SUV?
I believe that mostly SUV Max was being used, but nowadays like TLG and peak SUV and average SUV, these things are also being used for prognostication. Obviously, that when we calculate SUV max, it's just depiction of maximum activity in a voxel. So it really doesn't give very prognostic indicators. But if you use peak SUV, which see the surrounding around the pixels, around 26 voxels, and then it is calculated. That may be the better prognosticator. Another TLG is being used now, and I think that might be the better prognosticator for that. And that's why this talk, my talk, we will be little bit discussing about radio mix, which is another paradigm of quantitative imaging, and people are looking very positively towards that. Hope I have.
Okay, thank you. Sorry, thank you so much for the response. Now
this would have, yeah. You can do your question, and we can ask the speakers that you are for that. Okay, Mr. Hello.
Yes.
Is that okay?
Rajni, your voice is cracking actually. Dr. Rajni, your voice is cracking.
Hello.
Aisha, you can start now, I think.
Okay, thank you, sir. First, I would like to thank AFOMP for giving me this opportunity, and Professor Arun and Dr. Rajni. And today I am going to speak the role of artificial intelligence in precision oncology. This is a kind of new paradigm for medicine and oncology, and for medical physics as well, because I believe that medical physicist has capability to implement artificial intelligence in medicine and oncology. And
yes.
Yeah. So and I believe this is one of the sweetest challenge for a medical physicist to accept to implement that artificial intelligence in oncology. So we are going to discuss this topic these headings. You see the two cartoons, cartoon A and B. there might be two scenarios of implementing of artificial intelligence in medicine or oncology. So it should be B1, which is AI assistive to that our treatment algorithm. So let's discuss that each topic one by one. So when we talk about artificial intelligence, then we cannot forget few people, that John McCarthy, who was the first person to coin that term artificial intelligence, and that another person, Van der Bush, he first time proposed in 1946 proposed that machine can think. And the very important person in this chronology is Alan Turing. I think most of us must be aware about Turing test, and he was a genius. And at that time, he proposed that can machine think, and that was taken very well. And his paper published that computing machinery and intelligence mind in 1950. It is that the artificial intelligence, that is the process to develop intelligent machine outperforms the natural intelligence of human being. So it consists of mainly machine learning as well as big data. If machine learning, we will see in next slide. If we consider that big data, it stands for 5 B's: that velocity, verity, volume, veracity, and views. So if we see that 5 B's and we consider data produced in oncology or medicine, then you will find that we satisfy all the 5 B's, and we can implement artificial intelligence on that data and use this very novel technique for the assistance of patient treatment in oncology. So see that prediction analytics, machine learning is the method in which the machine learns from the past event and data without being explicitly programmed for that. What happens most of the time, computer works, we give a particular kind of programming, and based on that program, computer acts. But artificial intelligence, there is program, but that program is not explicitly performed to do a specific task. So let's take an example of simple logistic regression. And logistic regression can be applied for many kind of problem. The same algorithm can be applied to predict that particular with the help of some input value to predict some output value in medicine, in engineering, in say language processing, in many other ways. Then ML can be of 3 types: supervised learning, unsupervised learning, and semi-supervised learning. So major ML techniques can be categorized in 3 groups: one regression, one linear logistic, and k-nearest neighbor. Mostly we do regression with this, and then decision trees like random forest, classifier, support vector machine, Bayesian networks. These work with the principle of this decision tree. And then deep learning like convolutional neural network, recurrent neural network, and artificial neural network. See the pipeline to implement the prediction modeling in any field, say in the case of oncology or medicine, then we have various kind of data: clinical data, imaging data, pathological data, and genetics data. And we have that data. Now these data make the big data, and we need to arrange that data, clean that data. So cleaning, the first stage of prediction modeling is cleaning of your data to make the your data amenable to machine learning, and then you have huge amount of data now, and it is very difficult to have prediction model based on that. There are 2 major issues with that data. One is redundancy of data. suppose you have two features and both the features are having same kind of prediction for prediction endpoint. So that is called redundancy. So the redundancy you have, then you have multidimensionality of data. If you have so many features based on that, you want to develop a prediction model, and you have limited number of say A's based on which you want to train your model, then there will be difficulties. So in that process, we first we remove the redundancy, then there is two technique. One is data selection and data selection. What we do, we select the features, the best features for our prediction questions. Second is reduction of data. Reduction of data may be performed by using like you have, let's say, hundreds of features, and you just aggregated the feature and made the 3 features out of that. That is called reduction of features. And reduction of feature mostly we do with the help of principal component analysis. And in feature selection, we have various methods, like we have filter method where we use we can use any statistical algorithm like hierarchical clustering and hierarchical clustering and simple decision to find out that which is having correlation with each other. Then second step is recursive feature and elimination or lasso. There are various techniques which can be applied. Once you have selected the adequate model, then you have various kind of algorithm, and you never know that which algorithm will work better for your prediction endpoint. So we develop several models and try to validate that model based on our internal and external data, and then we select the best model which is giving you best result for your question. Let's understand about precision oncology. If you see that oncology itself, so it's like patient comes to us, we diagnose it, then we do the staging, and we select a particular kind of treatment, and we give that treatment and do the monitoring of the patient, then follow up of the patient, and sometime during the follow up you might see that there is recurrence of the disease, and then you do re-staging of the patient, again treatment starts, and then you follow up the patient. But in precision oncology, we believe that there might be some all same treatment doesn't fit for all. So our patient is not having only that disease specific. So each patient in the same disease group might have different kind of characteristic. So identification of that characteristic based on any method like by imaging biomarkers or biomarkers, and we treat that, we categorize that patient in several subgroups and give that specific treatment. One example is say take an example of non-small cell lung cancer, and if patient is GFR positive or negative. If the patient is positive, then we can use various tumor specific antibody therapies for that patient. And if you see that implementation of prediction, implementation of precision oncology, so currently we are treating like this. Historically or currently we are treating with organ-based treatments. Say it is lung cancer, so we give treatment for lung cancer. And very recently we have started getting several kind of biomarkers or imaging biomarkers. Based on that, we categorize the patient, and but it is not able to divide your patient properly. So then again, with the help of genomic and radiomic data, you can subdivide the tumor, and you can identify few people in a group which can be treated by a specific kind of things. But ultimate the goal should be to identify the particular patient, and then only we will be able to achieve the personalized treatment in oncology. And that can be achieved with multi-omics driven approach and implementing decision support system in oncology. One very nice study was performed by Accenture in 2 years back. They surveyed with 130 oncologists. Most of them were surgical, medical, and radiation oncologists, and they found that more than 80% wanted to implement that this precision oncology in their treatment, but they found really there is a problem, and in their study they found that adherence in the precision oncology is very less. Only 14% routinely participate in molecular tumor board, only 18% routinely use the clinical decision support system, and only 41% routinely match target therapies to genomic alterations. So they recognize this is very important aspect which do address these challenges, which will improve the implementation of decision support system in oncology. So let's discuss about little bit about radiomics. It is the quantitative imaging technique. So what is the pipeline of radiomics? We have medical images, and that medical images retrospectively or prospectively can be collected, and then you segment the tumor, or with that tumor we extract the radiation, extract the radiomic features, and with the help of that features we develop a prediction model to do the prediction modeling. Another very important aspect in the process of this implementing artificial intelligence in medicine is natural language processing. Why it is important? Because it gives you quick look of your data. You can process your data very fast, because majority of data are present in the form of free text, and if you want to mine that data and make it amenable to machine learning, then natural language processing is the way to go forward. So there is a pipeline which is being used for this. So if you see that first in this natural language processing, pre-processing, like segmentation of your data, stop word removal, tokenization, and word normalization. Then synthetic analysis. So synthetic analysis includes that synthetic parsing, part of speech tagging, and chunking of those data. Then semantic analysis, NER extraction and concept recognition. Then next step is negation detection. So there might be some negative term in your data, then you negate, you detect that negation. Then collection of NLP features and vectors for labeling, and then feature processing. That might be rule-based processing or machine learning-based processing or hybrid processing. So when we say that rule-based processing, we have some set of rule based on that. We do the feature processing, and most of the time it is better to use the hybrid technique. Then you have model development to define the outcome and generate the annotated corpus, technique selection, algorithm development, and training of model. Then model validation, it may be validated internally, and external validation is important if you want to have scalability across the world. Then you have model implementation, classification, decision support system, treatment outcome, and text report generation can be the different kind of paradigm which can be used, which can be where that NLP can be applied. So let's understand that implementation of this infrastructure in oncology, infrastructure in oncology. So if we see that majority of hospital is not having proper infrastructure to implement artificial intelligence in medicine or oncology. So if you see that we have different data sets, like clinical data sets in the text, you have icon data set and headers, and once you are doing radiomic extraction, then it is thousands of features are being generated. So these features can be extracted from there, and then it should be stored in particular format, in particular place from where that it will be accessed by the researchers, or it can be accessed by various partners for implementation of artificial intelligence in oncology. So in this image, you can see that we have developed a pipeline in our hospital which can extract the data from our HIS or EMR and convert it to that we say that I'm able to RDF format and stores in the SPRQL endpoint. Why this is important? Because if you see that research required, the amount of data required in to implement that artificial intelligence medicine, it is huge. And if you want to make an scalable model across the world, then you should have data from all corners of the world. But at the same time, there is problem of data sharing because of various ethical and regulatory norms followed by various countries. So other way to take up that challenge or meet that challenge is the distributed learning. So that infrastructure one need to develop. That distributed learning is nothing but data stays in a particular location or specific location. So suppose there are three or five centers which are participating in machine learning problems, then their data will stay in their hospital, their center itself, but that algorithm will move from one center to other center and learn from the data, and then weighted a comprehensive model will be developed, and that will be again tested on that particular data, and a final model will be developed which will be working for all the partners or all that, and that will be having scalability across the world. Then what are the trends in implementation of artificial intelligence in oncology? If you see this curve, if you see the trend of CT scan, increasing CT scan and biomarker and imaging biomarker, and you will see that after 2005-6, there is tremendous growth in this field, that artificial intelligence. Recently, we published an article in Nuclear Medicine Communication, and we have seen that from 2015 there is rapid increase in that radiomics-based paper and in oncology, and it is being accepted across the group. So let's see that examples of some clinical examples. So in this paper, a machine learning-based clinical decision support system to identify the prescriptions with high risk of medication. So in this, they have concluded that with the help of machine learning, they can predict that where that prescription is can go wrong. In this next paper, that risk prediction model of lung cancer, here that it has been this paper has reviewed that prediction model used in lung cancer, and they have concluded that there is significant evidence to use the prediction model in the management of lung cancer. This is another paper, and this paper has been published from our group from Netherlands, and this you can understand that the way artificial intelligence is being adopted in that oncology, that this paper is having citation of more than 3,500, and this paper is very well depicting how that there you can develop a phenotype based on imaging data, which can decipher that underlying genotype of the disease in lung cancer as well as in head and neck cancer. So in this paper, that artificial intelligence-based clinical decision support system in modern medical physics, selection, acceptance, and commissioning and quality assurance, it has been shown that how a medical physicist can help in implementing artificial intelligence in oncology. So Another very important paper I would like to cite here, that role of artificial intelligence in screening cervical cancer. So if you see that if only with clinical examination they were having chances to diagnose that predict that this patient will develop that cervical cancer is only 50%. With the help of pap smear and visual inspection both, it increases to something around 69 to 71%. But if you use the automated evaluation of this with the help of machine learning algorithm, then your this accuracy of detection increases as good as 91%. So there are some challenges in implementation of artificial intelligence in oncology. So in this paper they have enumerated that various aspects where that labeling of annotating of data is very tedious task that which can be taken care of by implementing NLP in your algorithm. Then segmentation, suppose you want to do radiomic analysis, then segmentation is very difficult task. So we say I want to have around say thousands and thousands of images to develop radiomic signature for particular endpoint in lung cancer. So you have to segment that tumor, and that segmentation is quite technically demanding. So for that, several automated segmentation techniques has been developed, which can be utilized. Then so second, then implementation of ML techniques, which technique you should use. And recently we have published a paper in NMC that radiomics a quantitative imaging biomarker, and we have enumerated all sorts of techniques which can be used to tackle that shortcoming in implementation of artificial intelligence in oncology. Another very important aspect is that with radiomics is repeatability and reproducibility. We can generate thousands and thousands of radiomic features, but majority of feature is not stable even on test-retest based basis, and we need to identify with the most robust feature, because if you have developed a model with feature which is not having stability, then this is not going to work for in your future work. So it's always important to have this study of repeatability and reproducibility and find out that most robust feature. In this study, we performed human cohort and phantom, and we found around hundreds of features have that this concordance coefficient of around 9 and above, and they are the robust feature, and those feature can be implemented in further study. We have used those feature, and they are having very good prognostication. At least we have used for 2 cancer type, cervical cancer and lung cancer, and we found that the importance of that feature in prediction model development. So implementation of machine learning in healthcare, addressing ethical and challenges. So there are 2 major challenges, ethical and regulatory challenges, that need to be discussed and fixed. So there are few groups in Europe and USA where that they have started this developing regulation to regulate this prediction modeling and decision support system, and that is one of the most important aspects to implement artificial intelligence in oncology. So implementation of CDS, how it will be implemented. So we can understand from here that suppose when patient comes to you, then you have various kind of investigation to perform. So once you have performed the investigation, you have this clinical decision support system based on radiomics, based on clinical data, or with multi-omics, and then we use that that platform to give you some sorts of direction how to treat that patient, what to do with that patient. And once you have treated that patient, and the patient comes for the follow-up and see that what is their outcome and whether that outcome is matching with your outcome, predicted outcome or not. If it is if it is not, then give feedback to that system, and how this is how it makes that self-learning based computer decision support system. And summarize that AI is going to contribute significantly in precision oncology workflow, leveraging digital phenotyping of disease linked to outcome may be the breakthrough in imaging, reproducibility of radiomics, NLP, AI need to be ensured. The medical physicist can play a major role in implementation of artificial intelligence, oncology and medicine. Then ethical and regulatory issues related to artificial intelligence implementation in medicine need to be discussed in length and width and fix it. Thank you for your patience hearing. If you have any question, I am ready to take that. Thank you.
Thank you so much, sir, for being with us and for such a wonderful talk. Now I will request all the participants, if they do have any sort of question, they can ask directly with the speakers. Dr. Ashish Jha is also there, and Professor Arun is also there. So for any questions, please feel free and write your questions. Okay, I guess we do not have any question. Even the presentation was so wonderful that it was really informative. Even I feel amazed about some aspect that AI is coming so fast in nuclear medicine. So thank you so much, sir, and I want to thank all our speakers for today's APOM School webinar. It was a wonderful session for all the people who are seeking some information in nuclear medicine. Now we have Professor Chogle with us. I think he's going to wind up the program. So thank you so much, sir. Please go ahead.
So thank you, Rajini.
Hello?
Yeah, are you able to listen to me? Is it okay? Are you getting my voice?
Yes.
Okay. So
yes, perfectly.
So thanks to Dr. Pankaj Tandon for organizing this wonderful APOM School webinar, and we had 4 excellent speakers. Thanks to Dr. Anshu Sharma for excellent talk. Then Pankaj Tandon himself gave a wonderful talk, and then Dr. Subhash Kiruka from Middle East, he joined to us, and last talk was from the Ashish Jha about the artificial intelligence and things. So thanks to all the speakers for giving a insight into the topic they have chosen and given huge amount of knowledge to us. Thanks to all the participants for joining and taking interest in this APOM monthly school. Thanks to all my APOM ExCom, Junios, the chair of the ETC, Chai Hong, chair of the PRC, Rajini Verma, and everyone. As you know, we will have the next APOM school webinar on 26th March 2022, and this will be on the actually leadership in medical physics, how important this is, and Carmel Karuna will be speaking on this thing. Already on the APOM website, the information is there. You can log on, and also we have in the month of April, in the month of March, we have another meeting on Friday, that is the 4th, and then we have upcoming the AOCMP 2020 in Taipei, Taiwan during 10 to 12 December, IUPSM World Congress in Singapore during 12 to 17 June 2022. The late abstract submission is on. If you are interested, please do join. So once again, I thank all of you, all the speakers, Dr. Rajni Verma for moderating excellently, Dr. Jin Xian, Chai Hong, and everybody. And this actually FOM school is ACPSM CPD accredited, and you will get 6 points for this and certificate for the attendance. With this thing, thanking each one of you, we close and we'll meet on 4th of March for FOM school and the 26th March for the FOM webinar. So
I have to say something. Actually, we have some question and query related to certificates. So the certificates for FOM school program we have started now only. It was not there earlier. So you will be getting certificate now onwards, not for the past FOM school. So you can write to Dr. Chai Hong directly for the certificate for today's FOM school webinar, not for the past ones. So I think this will be helpful to if you are looking for certificate, asking for the certificate. If any question related to certificate is there, please you can ask us now also, and you can write to us also, and you can directly write to Dr. Chai Hong also. So thank you so much all, and
thank you Dr. Rajni for all the wonderful session conducted, and I'm really thankful for giving us an opportunity to be with this FOM this time, and hope
it's my pleasure, sir. Pleasure, sir.
Thank you very much, all of you.
We have it.
Good. Okay. Thank you. Thank you. Bye bye.
Thanks, Anu sir and Rajni madam. Thank you so much.
Thank you so much, sir.